So, hello, good evening, everyone, and welcome back to one of the another sessions of the CCI web series, which has been going on since more than a year now. I would say it's one of those grandstand series of webinars which is being organized by CCI and attended by thousands of people almost every week. So, this week we are going to keep it simple about the most important and the contentious topic of COVID, that is the therapy of COVID, about the most contentious drug, that is Remdesivir. It was kind of a poster boy when it came in, suddenly fell into disrepute, then it fell out of stocks, and our experience somehow has always been consistently pleasant despite the flip-flops by the industry, despite the flip-flops by the central agencies, despite the flip-flops by the WHO. The confusion reigns. Howsoever, our attempt today is going to be by a panel discussion is how exactly are we still going to position Remdesivir in the treatment of COVID-19 with a lot of new kids on the block. Roche is already there with the two new antibody cocktail. I call it CNIB and INIB because the names are simply too big to be pronounced. And we just get on with the discussion of this particular old but very important molecule, Remdesivir. We have on panel today people from across the country. We have Dr. Pratibha Singhal from Mumbai. She's a dear friend and colleague. She works at Mumbai Hospital and Harkishan Das Hospital. We have Dr. Chandrakant Tarke. He's from Hyderabad Apollo Hospital. And it's going to be very interesting to listen to him because Hyderabad is right now witnessing, as he was just telling me, surge. We have a very young and a dynamic chest physician from Goa, which he tells me that the positivity rates are highest in the country, close to 50%. That puts everybody's plans of vacation on hold for at least next 6 months. And from the other end of the country, we have Dr. Abhishek Agarwal from Guwahati, and the recent there is an upsurge in disease in there as well, which till date was one of those areas which was almost locked away from the very high surge, and they are really facing the brunt. And one of the doctors is still not with us. Dr. Santosh from Karnataka is probably still not joined us, but he should be there with us. And I just received a message that he'll not be able to join because of some emergency. Not unexpected looking at the present times. So Pratibha, let's get on with the story. What is all with this Remdesivir? How did a drug which was essentially meant for Ebola even find its way into the treatment of COVID? What were those specific two large trials or data which came in, which pushed everyone into this bandwagon, so much so that the world is almost dried up of this molecule? Pratibha.
Yeah, so I think there was data on Remdesivir, not just in Ebola, but also in MERS and SARS and in other coronaviruses. And I think very initial studies which studied Remdesivir showed that the EC90 value was 1.76, which is of good virucidal value against specifically the SARS-CoV-2. And that is how the use came. They decided to study this. I think the first study that was there was a very small study published in NEJM in April 2020 of just 53 patients where they studied the compassionate use of Remdesivir, and that is where this whole story started. So small study, 53 patients spread out with 20 patients approximately over the US, Japan, and Europe. And they found that patients who received Remdesivir and had oxygen requirement, they had a 68% improvement in oxygen requirement and 57% patient in extubation rates. And that is where this whole story started and set off the introduction of, the publication of the Lancet study by Wang in 2020 again, where this was an RCT where they had a total of 237 patients randomized into the Remdesivir and the control group, and where again it was basically on patients who had pneumonia, documented pneumonia with oxygen requirement of less than 94%. So they were obviously not looking at patients who were not on oxygen in the initial phases. And their primary endpoint was basically time to clinical improvement, which was based on the clinical ordinal scale. And they found that even though statistically there was no difference in the two groups, the numerical time to improvement was slightly better in the remdesivir group as compared to the placebo group. And this set off the ACTT trial, which was basically the adaptive COVID-19 treatment trial, where a much larger population of 1,063 patients was randomized into the placebo and the remdesivir group. And these were patients who were in hospital and who had evidence of lower respiratory tract involvement. Now, the interesting thing in the ACTT trial was that it included patients who were not on oxygen, who were on low flow oxygen, who were on high flow oxygen and NIV and invasive ventilation. So there were 4 treatment arms in this entire study. And that is where they decided that their primary endpoint will be time to recovery, and secondary endpoints they will look at the clinical status and the ordinal score. So here, I think if somebody really reads this trial interestingly and looks at the rate to recovery graph, one will realize that remdesivir actually probably the only group where it had a positive shift from the central curve was in patients who were on oxygen, not on NIV, not on invasive ventilation. Okay, so I think that is a group where when patients were started early, within 10 days of symptoms is when patients actually, this group of patients had some actual positive response. The other patients, there was not that much difference in between the placebo group. So I think what we are looking at here is, a gray area between, we are all talking about remdesivir doesn't work in sick patients. I think all the data that is telling us is actually it never worked in very sick and ventilated patients. Okay.
Pratibha, I would like to interrupt you there. Yeah. I would rather go back into your presentation or the answer which you gave me, that there was a valid hypothesis to first use the molecule, that it is a virucidal drug.
Absolutely.
It was also found that it reduces the length of stay of the hospital beyond any doubt. And if someone's length of stay of hospital is reducing, it basically means that there is a faster resolution of symptoms. That is the bottom line.
Yeah. So that's what, coming back to the ACT trial, they showed that patients who were in the remdesivir had a 11-day recovery versus a 15-day recovery in the placebo group. And the mortality in their study was 7.1 in the study group compared to a 11.9% in the placebo group. However, when you look at the subsections of the various arms, the maximum benefit was in patients who were on oxygen, but not on high flow or NIV.
Yeah, so that's why I'm, Pratibha, interrupting you, because that is some part of the discussion which I'm going to take it completely separately. The other part where exactly are you going to position this molecule and prevent the abuse of this molecule. But what I wanted you to get out of these studies was that this is just not somebody's figment of imagination. As things are happening, give methylene blue also, give that also. This was a very well hypothesized drug that there is virucidal activity. There were trials to back it up that there is some effect, but we are not promising any miracles. It is just that over expectation out of this molecule really overran this molecule itself, that it has fallen into disrepute, which also we will discuss. There are always pros and cons to any molecule. So I'll just be coming back to you, Pratibha, but then the offshoot of this question, I'm going to put it to Rahul, that in all these studies which were being done, you have now a plethora of patients, especially in the second wave. We've been having patients who are very young coming to us, or large group of patients is the one between 20 and 40, not that earlier wave which we had only the middle age to the elderly population coming to us. What were those age limitations of using this drug? Say, for an example, if I tell you that somebody who's less than 10 years of age, but 45 kgs, means pretty very healthy, very young people, or very old people, what are the age limitations which you would rather not use this remdesivir, or there are no age bar to the use of this molecule at all?
So there are age limitations to this molecule that they have mentioned in their product monograph. So less than 12 years is the age limit. So I would not like to give this drug in children less than 12 years. And considering the geriatric population, there is no age limit specified. However, we have to take into consideration the hepatic and renal dysfunction in these patients. So if I put it forward, then the EGFR that is less than 30 ml per minute per meter square, or AST and ALT elevations of more than 5 times upper limit of normal. These are the criteria which are taken for elderly people.
So if I were to make it more simpler for you, Rahul, I would say that the EGFR calculation very heavily depends on the age of the patient.
Yes.
And the EGFR almost halves if your age of the patient is more than 80. So
Yes.
thereby, when you go towards an extreme of the population, your almost the estimate of EGFR is so high that you have to be very, very careful by using this drug. Am I getting you right, Rahul? Is that what you're trying to tell me?
Yes, sir. Yes, sir.
Okay. So, Pratibha, now I'll come back to the same trial. Like the Ministry of Health and Family Welfare has clearly positioned this drug. Of course, there have been flip-flops and they put on and off. AIMS has put it off its protocol altogether. There was a subgroup where it was not positioned at all. It was not positioned at all in the mild variant.
Yes.
And this was done because none of these trials were actually showing that it benefits. So can you elaborate on those trials where there was, what was the benefit in those subgroup of patients who had a mild disease?
So I think the ACTT trial is the only one where they had really included the mild patients, not on oxygen. Most of the other studies have been done on patients. Almost all the other studies are on patients who had oxygen requirement. So in that subgroup also, there was no benefit of remdesivir, which is why it was never positioned for use in patients who were mild, who did not have some oxygen requirement. So maybe that's why it was only initially positioned only in the moderate and severe category, because all the trials were assessed in that category, and only one trial which used it in non-oxygenated patients did not show any benefit.
Yeah,
as compared to the placebo arm.
That is very important. Then that's why Dr. Chandrakant, if you could come in over here, as Pratibha has rightly put, in all the trials when you discuss science, they are discussing clinical severity. They are discussing whether the patient was on oxygen or not on oxygen. Nowhere has it been ever mentioned that the CT severity score should be used as a marker for introducing remdesivir. What are your thoughts on this? Like, where should we be placing it? Like, if you have a CT score more than 9 or 10, but this patient is stable, you haven't really seen the CT score to score it yourself. Probably you would score it lesser. But the radiologist tells you that the score is 10, patient is sitting in front of you, hale and hearty, no desaturations. Would you be wanting to? Can you just elaborate on this kind of a setting, which is clinically mild, and the use and abuse of remdesivir, which has been rampantly going on? And you in Hyderabad, where there is an upsurge of disease, there must be a severe shortage of this molecule at this point in time.
So this is an excellent question. Many people go by the CT severity rather than the clinical situation. First, we need to see what is the mechanism of action of this drug. This drug prevents viral replication, especially in the first week of illness. That is more predominant mechanism is pathophysiology. And as the disease go into the second week, later on the viral replications comes down, it will be slower, and more there will be inflammatory phase. So basically, whatever the studies are there, but what we experience and whatever my experience is there, this drug works well, especially reducing the severe symptoms, especially fever comes down if you start earlier within the less than 7 days of illness, and rather than the severity, if the patient, even if the CT is normal, but the patient is running fever of 100 to 103, if you start the remdesivir in such cases, it works better. Okay, and to reduce the symptom duration. But once, for example, as you said, the CT severity of 9 with the patient is absolutely fine with the minimal symptoms, and this means that at the virus is ceased to multiply, the multiplication rate is lesser, but the CT is showing the feature that means inflammation or microthrombosis is there. In such cases, definitely I will not prefer remdesivir especially if the disease duration is more than 10 days.
Absolutely true. Absolutely true. In fact, I would just like to add a corollary to your explanation, Dr. Chandrakant. Like, is hypoxia the only marker of the severity of the disease? Like, there would be patients, and there are patients which we see every day who are normoxic, but have started developing some degree of hemodynamic instability, mild hypotensions. Is that a contraindication to use because their renal output has started falling down, or it's the other way around, that that's a possible indication of a severe disease and you would like to start them on remdesivir early? What are your thoughts on that? This is the question which is coming from Uttar Pradesh. An excellent question. What about hemodynamic instability, mild hemodynamic instability as a marker of severity of the disease?
If the patient is hemodynamically unstable, but if the disease duration is less than 10 days, definitely we can give the remdesivir. Regarding the nephrotoxicity, the trials which they have excluded when the EGFR is less than 30. But as for the discussions of our nephrology colleagues, if you give the remdesivir for 5 days, even with the patient with the CKD, it's safe to use it. Okay, only for long-term duration we can't use it. That's why even with the patient with the AKI, CKD, and for short-term duration, we are using it, and we found to be not harmful. So that in such patient, if the disease duration is less than 7 days, 10 days, we can use it even though if the patient is hemodynamically unstable.
I would just like to make it lighter by one beautiful question which is coming from Poonch, Jammu and Kashmir by Dr. Mohammad Idris. He wants me to summarize this webinar in a nutshell even before it's over. So I just, Dr. Idris, let me finish it up. I'll summarize it in a nutshell.
Can I add something?
Yeah, please, Pratibha, please go ahead.
So, I think the renal dysfunction, has been given too much importance as far as remdesivir use is concerned. I think sometimes, patients come in AKI simply out of fever and dehydration. Okay. So I think if we are suspecting that it's related to dehydration, sometimes as Dr. Chandrakant said in consultation with the nephrologist, we have used remdesivir even in patients who have had AKI with hydration, and actually the creatinine has come down because the AKI is due to the disease per se also and not necessarily drug induced. So of course, there you have to monitor the creatinine, you have to be in consultation with your nephrologist regularly, and it has to be a team decision.
Yeah. So if there is a pre-renal azotemia, please go ahead and give it. But if it's an ischemic problem because of microthrombi and all that, you'll have to be.
So one more point I like to add.
Yeah.
So one point I like to add, sir. So in case of AKI cases, whichever I have tried in my cases, patients' creatinine used to come down with treatment with remdesivir, sir. And they used to measure the creatinine before giving the remdesivir, sir. And in fact, only 1 or 2 cases, patient who had renal transplant, only in that case we have problems, sir. Otherwise, in not a single patient we got any problem with remdesivir in AKI or CKD, sir.
Oh, well, I have actually had 3 patients who went into acute renal shutdown post remdesivir, but of course, I was unfortunate in that. But then, Dr. Abhishek, let's continue. What made WHO drop remdesivir from the list of essential drugs? What motivated them to get it out altogether? Like, it was just from this end. I remember the series Yes Minister, where the minister has an in tray and an out tray, and if he does not want to answer any questions, he just puts the envelope from the in to the out tray without reading it. So what made WHO put remdesivir from in tray to the out tray? Is it that remdesivir, whether given in the moderate or the severe cases, has never shown any major benefit? When you tease the trials out, tease it out, you realize whether those benefits are real benefits or only numbers. So what are your thoughts on that? Why did WHO do that?
Sir, WHO last year in 2020, sir, conducted a solidity trial, sir, in collaboration with more than 30 countries, more than 500 hospitals, with enrollment of more than 12,000 patients, sir. In that study, the interim result came out last year, October, sir. They found that there was no mortality benefit with remdesivir. There was no reduction in the hospital stay of patient compared to placebo. And there was no improvement in patient need of ventilation, sir, assisted ventilation. So after seeing this interim result, WHO just dropped out this molecule, saying that it has no benefit in this patient, sir. So, but clinically, if you see in our experience, there is a lot of difference, sir. So we can see a definite improvement in our patients who are on oxygen, sir, who are on BiPAP, sir. It's not that if the patients come after 10 days, as Chandrakant sir has told, in that case, we are quite hesitant to give remdesivir. But when patients have come to us on day 3, day 4 with high oxygen requirement on BiPAP or high flow nasal cannula, patients have improved, sir. In fact, in last few days, I have 3 to 4 patients, sir, who have improved with remdesivir and my steroid therapy. But we don't know which molecule has worked, sir. But patients are improving, sir.
So, Dr. Abhishek, let me play the devil's advocate. These are not my thoughts, but I'm just playing the devil's advocate. Just as a corollary of the previous discussion on renal issues with remdesivir, that with WHO dropping it out, with AIMS protocol not having any antivirals, neither favipiravir nor remdesivir in their protocols, our experience, my experience too, not really in consonance with these observations, and you have a patient with AKI, how motivated would you still be to take a chance and put the patient on remdesivir with this changing, this ever changing and the dynamic situation of treating COVID? And it's just not treating COVID, personal experience, and patient and relative perception. We have to keep these three things.
Sir.
And these perceptions are changing by the medical information, which is also in public domain today.
Definitely. So
So
definitely,
how would
sir.
your decision be influenced now?
So daily news released by lots of medical experts, news interview by in the news channel, sir. Now it has become difficult for us to treat patients, sir. Even if you can write a CT scan, patient will ask, sir, whether I will have cancer, sir. Now remdesivir also has become the same molecule for us, sir.
Yes.
So before starting remdesivir, you always used to have a talk with our attendants, sir, patient attendants, because we don't have much options, sir. Either steroid, remdesivir, low molecular heparin, or plasma, sir. After having a detailed discussion with attendants, if they agree, we go with remdesivir, sir. And our experience was quite good, sir. And I already pointed out, sir, only 1 or 2 cases who had renal transplant patients, sir. They have some problems, sir. Otherwise,
I'm going to ask you, you wait for that. Santosh is not coming, so you are going to be pinned on that question. So that's a nice thing. ESRDs and remdesivir, it's going to be an interesting discussion. But before we go there, Rahul, can you now summarize all the issues, all the confusion surrounding the the use of an administration of remdesivir? What would you look at before giving remdesivir? What would you be looking at while giving remdesivir? And even after remdesivir, the story doesn't stop. I personally have had elevations in creatinine 3 or 4 days after remdesivir has already been given. So what would you be looking at constantly while remdesivir means just everything around administration of remdesivir? Is it just monosef, 1 gram BD, give it, forget it?
No, sir. So I would look into the first and the foremost criteria would be a duration of symptom onset less than 10 days. So remdesivir is found to be effective only during the first 10 days of illness, that is during maximum viral replication. So this is one point. The second is we have to reserve this drug for moderate to severe cases and those requiring oxygen supplementation. In the first wave, as we saw that we used to give remdesivir for even mild cases with comorbidities like diabetes, hypertension, or any cardiac issues, so that they do not progress to severe disease. But now, as we have a lack of supply or stock, we have to reserve this drug for moderate to severe disease. Third is patient should not have any renal or hepatic dysfunction, as I mentioned earlier. If and even during administration of the drug, we have to monitor the RFTs and LFTs every alternate day. And at any point of time, if they go above the criteria, then we have to stop the drug.
So I'll just stop you on that. There is a question which has come on the chat box. If we stop the medication, let me just read it out. If we stop the medication because of the constraints, when can we restart? after how many days can we restart? Because as we have stopped the medication for a few days, the length of the disease is also increasing, and it's sometimes it might even go beyond the length of the viral replication. If at all, would you restart? And if so, after how many days?
I would like to monitor the RFTs and LFTs every alternate day. If they fall within normal limits, then I would like to restart the drug. And duration probably is more than 5 days is not advisable for remdesivir. It can go up to 7 to 10 days.
Fine. So are you trying to suggest that if you stop it for 2 days, you will restart and finish off the dose, or will wait how long?
Preferably the duration should not cross more than 10 days from
of
symptom
the
onset.
Of the disease. Okay. One interesting, before Pratibha, that one interesting comment has come in. I want you to add something after you listen to this question, because it needs clarification. When Dr. Prasad from Telangana, Hyderabad, has very politely stated that if I understand, all the panelists are still recommending remdesivir as a treatment component, contrary to the WHO opinion. Is it so? The improvement told by you all can be termed anecdotal, question mark, quote unquote. Pratibha, now you can add.
So there is data published by our Bangalore colleagues also, by Mehta, Dr. Mehta. There is publication which says that there is improvement. They have seen improvement. I'm sure if we all speak to all our pulmonology colleagues, it's not like everybody is going to improve. Okay, but all of us have seen that there is improvement in some subcategory of patients. Now, the logic is, if there is in response to the WHO solidarity trial, there is a very interesting publication recently in Lug India which talks about placing the results of the solidarity trial with regards to remdesivir in perspective. This was a review of all the trials on remdesivir, including the solidarity trial, and how various objectives were discussed. I think one must read this to understand that we are a country where, if we are looking at even a small sector of population, we have a large population right now, a lot of cases. Even if we are looking at some of them recovering early, because our time to recovery is also what is important. If hospital stay goes down in certain subclass of patients, then we are looking at early discharge and early bed recovery. I think that is also important. So I'm not saying that we should remove it completely. At the same time, we have to take all the data available in perspective and our own clinical experience in perspective.
Perfect. So basically, we are not here to throw it in the waste paper basket. We are not condescending it. We are not relegating it to the corner of the room. It's not indispensable and it's not useless. We have to understand two things. WHO has dropped it from the list of essential medications, number one. And if you look at the Maharashtra task force where I and Pratibha belong to, we have still labeled it as an experimental therapy. We are not going hungo about and going against WHO. We are not saying that it is an essential medicine. We are still saying that the essential core of the medicine is steroids and anticoagulants and oxygen. But if available, the benefit is there for taking it, with the restrictions which are to be applied to the use of the molecules around the side effects of the drugs. I hope that satisfies Dr. Prasad. Nobody has over here any intentions of propounding their own personal science at all. So this is where I would now,
various scientific bodies, I think, are in conflict over this. Like, if you see, the US FDA gave it permission as a regularized drug because it gave it approval in pediatric and adult population. That means it came off the list of reserved drug or experimental drug. Whereas I think other WHO is and in our Maharashtra task force we are still talking about it. So I think we're still in conflict over its use. There is too much of data evolving. It is the molecule, the virus itself. There's so much of mutation that is happening. So I'm sure there is a lot of, now the Act 2 study which has come has shown good results in combination with remdesivir plus baricitinib, however So there is a lot of data that is, all these complicated drug names.
BNIB.
Sorry?
So that is BNIB for me. That is CNIB, INIB, BNIB.
Yes. So, there is too much of data floating around. So I'm sure there is going to be conflict. So I think what we need to also look as place all this data in perspective. I must say that you all must read this Lung India article, because it has taken all the publications that have been there so far, and it has given that, all publications, we are looking at the rate to improvement ratio, whereas the WHO trial, the Solidarity trial, was only looking at mortality benefit as their primary objective. So I think that is where there is some conflict on the various trials. Maybe if we go through it ourselves and formulate our own opinion and take our own judgment.
I think we basically, as Pratibha is trying to tell, and I'm sure all of the panelists over here need to agree, that we need to keep a broad, open mind. We don't need to be arrogant about it, that it is my opinion, to mereko acha laga, I have found this, so I will do it. No, we are doing it because not only we ourselves are seeing benefits, our colleagues are seeing the benefit, and it is being seen everywhere. At the same time, we are definitely keeping it in mind. If I don't get Remdesivir, I'm not going to boil my blood over it, because it is not a panacea. So now this comment, Dr. Chandrakant, is Remdesivir a panacea, an indispensable drug for the treatment of COVID? That answer should settle off all the arguments that has been going on in my chat box.
It's not an essential drug for COVID treatment, especially mortality point of view, but definitely it reduces the symptom duration, as we discussed as of now. And because whatever our experience is before Remdesivir also, we started seeing the COVID cases since April 2020 in Hyderabad. Actually, the first case which was detected in South India, that Gulbarga case, transferred from the Hyderabad only. We started since beginning, and that time Remdesivir was not there. And since beginning only, going through the pathophysiology and inflammatory phase, we started using the steroids in the second, especially day 5, day 7 in April, May, June of last year, 2020. And compared to the current scenario, mortality is not much changed. Okay. Now also, whatever the colleagues who are not getting Remdesivir for their sick patients, whatever experience is there, there is not much difference. Patient who are receiving Remdesivir, not receiving Remdesivir, there is not much difference. And whatever they are improving the other medicines, steroids and all these things. Only thing, symptom-wise, as we said, definitely some symptom duration will be less with the use of Remdesivir.
So, Dr. Rahul, few questions are coming up regarding the administration of Remdesivir, which you so beautifully summarized. Any specific drug interaction to be looked into while deciding on Remdesivir?
Particularly, we have to look into hydroxychloroquine, which should not be administered along with Remdesivir, because it inhibits the metabolism of the drug.
Yeah.
And also, since Remdesivir causes prolongation of QT interval, it can lead to bradycardia. So certain drugs which cause prolongation of QT interval should not be administered.
Especially azithromycin, which is always used.
Yes, sir.
There are a few more questions for you, Rahul. Like, there are people, somebody has just posted, like, we just said that we found improvement, and this gentleman has saying that he has even seen patients with fever put on Remdesivir and their fever abating. Would you advocate, on the basis of such observations, administration of Remdesivir, who are not moderate or not severe cases but persistently febrile, the use of Remdesivir? Or would you be using the other group of drugs? This is Dr. Chandrasekhar Puttuswamy from Karnataka, Mysuru. Would you advocate the use of other anti-inflammatory drugs in such a situation?
So I would like to see the duration of symptom onset. If it is within 10 days or the early phase of the viral replication, then I would like to use this drug. So suppose if there is a person having persistent fever in spite of taking the other drugs like doxycycline, ivermectin or favipiravir, fever not settling down, clinically not improving, then I would like to give a trial of Remdesivir. And also the other criteria, which the person should have pneumonia and his saturation should be falling, that is less than 94%. Now we take it as 92%. Since the drug is not available or in short supply, we have to reserve this drug for severe cases.
I think Kumar's connection is weak.
Yeah. Maybe.
So to continue that, I think the question was basically about only fever in the absence of hypoxia. I know a lot of general practitioners tell their patients, your fever is high, go to the hospital, get admitted for Remdesivir. So I don't know what is the consensus about the rest of the panelists.
Ma'am, I like wait one point. So before starting Remdesivir, I will like to go with steroid, ma'am, in this case of fever, sir. And I have seen cases getting resolved in home only with steroids, sir. If patient starting steroid after 2 to 3 days not resolving, he's started having hypoxia, then I would like to start Remdesivir in that cases, ma'am. The duration is less than 10 days.
But how early? Because there is some controversy about early steroids will actually increase the viremia.
So, ma'am, that depends on the duration, ma'am. If the patient is coming on 4 or 5 days, ma'am, then again the history part is also important in these cases, ma'am.
Absolutely.
Ma'am, patient used to tell us that history of 2 to 3 days. Then we have to take that. We have to plus minus 2 days, ma'am, because patient may have mild body ache, mild leg pain, which he used to ignore as his symptom, ma'am. Then we have to start straight depending on our history, ma'am.
I guessed I lost you guys in middle, so I will just try to go back to Rahul. Rahul, are you propounding that you would start Remdesivir in a persistently febrile patient with a history less than 10 days before the introduction of steroids?
No, as I said, sir, I would first see other parameters also, like inflammatory markers, that is a D-dimer or ferritin levels.
Let me give you a classical hypothetical case, but absolutely commonplace. Patient febrile, tests on day 3, get the results on day 5, continues to have fever, and by the time he connects with you, usually it is day 6, day 7. He is normoxic, a 6-minute walk test. He does not desaturate at all. Fever goes anywhere between 100 and 101. His inflammatory markers are borderline elevated. LDH in such situations is usually normal. The CRP is usually in double figure. Ferritin sometimes in and around 400, 500 ranges. And the key figure, the big D dimer, is between 500 and 1000. This is the most common case, the most gray zone case which everybody faces. Is this the case which would push you to early introduction of Remdesivir? This is the primary question which has been coming on my chat box again and again. Would you be tempted for the early introduction of Remdesivir in such a case? And I would like each one of you to give your opinion, and then probably I will chip in if appropriate.
Yes, sir. So I would like to introduce Remdesivir in such subset of patients whose fever do not subside even after the other antivirals or other supportive treatment. So
you mean even after steroids?
Yes, sir. I would like to give, especially in patients who are having comorbidities, so that they do not progress to severe disease and they start desaturating.
Okay. What do you think, Pratibha?
So, a little controversial here, because at one level we talk about steroids increasing the viremia, and then we want to introduce steroids early.
Yes.
So
but I'm on day 7. This is already day 7.
Day 7. Okay. So
by the time he comes to us is usually day 6, day 7.
Day 6, day 7. So on occasion, I have been guilty of giving Remdesivir in the absence of hypoxia. But these are
we all have been, Pratibha, don't worry.
No. So I have to admit I have been guilty of it. And so let me explain why. So
that's extremely transparent and pragmatic of the Pratibha, I know. You are what you are seeing.
So these are patients who are running continuous fever 101, despite having received other so-called antivirals, okay, who have comorbidities, are probably diabetic, hypertension, maybe have an underlying airway disease also. So in some of these, I have been guilty with evidence of pneumonia on the CT scan. Okay, so maybe not really, and I think in some of them they have progressed to developing hypoxia. So I have been justified in starting Remdesivir maybe a couple of days early than what one would have done when they developed hypoxia. I don't know. What about Dr. Chandrakant? What do you have to say?
Yeah, Dr. Chandrakant,
As you
please. This
said,
is contentious.
days 5, 6, 7, as you said, kids earlier only. So definitely we have to go ahead with the remdesivir in such cases with the persistent fever beyond day 5. But additional thing, it's not that only remdesivir. Simultaneously, we have to think for the steroid also, because the persons who are getting even a fever after day 5, definitely if you don't interrupt it, later on they will go into the frank inflammation and high CT scores, respiratory failure. So we can think for the steroids on day 6 and day 7 in such cases, along with the remdesivir.
So sometimes I say, suppose the CRP was high in the case scenario that you gave, and the inflammatory markers were higher. It means that our day of illness is probably wrong, right?
Not really, Pratibha. So I was about to give you my personal input, but before that, I wanted to put another question to you guys. Sorry, just hold up, Prati.
Yeah. So I think here, based on some, as Abhishek was saying that the history of duration is very, very important. Yeah, I think very often what we get is very wrong information from the patient, and we really need to go back into the history.
Yes. So before I wanted to give my opinion, I just wanted to ask everyone's opinion and what the data says. Does remdesivir prevent the progression of the disease? The only drug which we know has to date prevented the progression of the disease is steroid, given in the right time. The recovery clearly showed that if you introduce steroids early, there would be more mortality. You introduce it on the right time, you can prevent the progression. Or rather, if you give it early, it makes the progression faster. And if you give it on time, it retards the progression. So what do you guys think about the role of remdesivir in retarding the progression of the disease? All of our thoughts of starting remdesivir at the various points in time which we have discussed are influenced by a feeling that remdesivir actually reduces the progression of the disease. What has been your personal observation, notwithstanding what the literature says? We are always going to be eventually bound by science and literature, but this is where I would like to have your individual opinion as experts and all panelists. And I believe every COVID doctor today is an expert, having treated more than 2,000 patients each easily. So what would be your personal take? Does remdesivir actually prevent progression of the disease? You can start, Pratik.
You want me to start?
Yeah,
so maybe in the moderate category,
yes. We started the second wave, so you can start
So let me go back to, since we're talking about personal experience, okay. So I have worked in Seven Hills, which was the first commissioned hospital for COVID in Mumbai, okay. And as well as Bombay Hospital, seeing COVID patients regularly. Now, we treated lots of patients before remdesivir and after remdesivir. In the moderate category of patients, where patients were on 6 liters, 8 liters NRBM, in them, definitely the turnaround time was better post remdesivir, but not in the sicker patients.
So that has been your personal observation.
That has been the personal observation. And yes, we were giving steroids earlier also in these patients, right? So the only additional thing that was added was remdesivir plus steroids. So I found that in the moderate category, there was some, the reversal time was faster, the progression time was lesser. And I'm not saying in all patients, but I feel that it was better in the moderate category. In the severe category, I don't think remdesivir would really have any role in.
Yes. So Dr. Chandrakant, if we were to plot a graph, pre-remdesivir era and post-remdesivir era and mortality in Hyderabad, what would you feel it would be?
So first I want to answer the first question, Miss, what is remdesivir's role? Progression, regarding progression of the disease.
Yeah.
But Miss, theoretically, if the patient diagnosed of COVID and day 2, day 3 of fever, that is the actual phase of viremia. But practically, patient will not get admitted on day 1, day 2, or day 3. Ideally, that is the right time to start the remdesivir. Whatever the role of remdesivir is there, to prevent the progression. I think day 1, day 2, day 3 of illness, it can be beneficial, but practically patient never gets admitted on these days. But later on, when the patient comes, by that time already viral replications comes down and mainly inflammatory phase starts. The remdesivir will not help much. And yeah, regarding the personal experience, whatever you experienced, miss not miss even second-hand experience from the other my colleagues also. Many patients, those who comes for admissions in the within first 7 days, gets the remdesivir for 5 days, then goes home, again comes back with the CT score of 20. In the initial score, CT score of 5, they come back to CT score of 20 and hypoxia, and they got admitted. If you don't give the steroids at the time of discharge, especially if there is a high CRP, and that's why we have to identify the patients at the time of discharge, especially those who comes for just for remdesivir, taking remdesivir and going home, having the CT findings plus high CRP, we should give the steroids at the time of discharge. And regarding pre-remdesivir and non-abdel remdesivir in some hospitals, pre-remdesivir era and remdesivir era, my experience is similar. There is no change in the mortality in the presence of or absence of remdesivir.
That's a very
That is my
very
experience.
honest statement to make.
Remdesivir will not make any change regarding the mortality. This is my experience. Guidelines may vary, but this is my experience.
And in fact, Rahul, I will put the question in a different scenario. Even as of today, when remdesivir is available or remdesivir is not available, are your patients doing differently in any way?
I didn't get your question, sir.
Say you have a cohort of 5 patients in your ICU and 2 somehow managed to get the remdesivir from some sources, 3 didn't manage to get remdesivir. Did all the 3 patients die?
So as madam said, Pratibha madam said, ki in the severe cohort of patients, it does not make any difference to the outcome. So the only those having the moderate disease and maintaining on low to moderate flow of oxygen, they will be benefited by remdesivir.
Okay. Yeah.
I think the
Abhishek,
thing that we need to promote is that, in the middle, at least in Mumbai, there was a shortage of remdesivir in the peripheries and people in the peripheral hospitals, and relatives were running helter-skelter trying to mobilize remdesivir. Okay. I think what we are all trying to say, if it is available, use it wisely in the correct category of patients. If it is not available, please don't give the illusion to relatives that their patients are not doing well because they are not receiving remdesivir.
That is what I wanted to actually, I'm coming towards the end of this whole discussion. I've just been informed that 1,350 people have logged into our session, and I'm sure somebody must have logged in only to hear the summary. So the summary I would like, in fact, the most important part of the summary I would like to get into the discussion is absence of remdesivir, either by legislation or by guidelines or by sheer unavailability of the drug, going to cripple our therapy in any way or outcome of these patients in any way. Quick thoughts, each one of you, such that I want everyone listening to us to understand that we are not here to market remdesivir. We are just trying to present science as is. We're just trying to present, we are 5 of us, so that accounts to almost experience of about more than 10,000 patients. Just trying to recount experience of 10,000 patients who received or not received remdesivir. And I also want each one of us to give an honest opinion that would absence of remdesivir by legislation, by guidelines, or by sheer unavailability would hamper our treatment in any way. We can go the other way around now. We can start from the distant most part of the country, Guwahati, 3 hours air ride.
Sir, definitely, sir, it's not like that with patient without remdesivir are not improving, sir. We have patients when there was out of stock in market, patient were improving with remdesivir, sir. We have to decide which patient needs it, most important, sir. It's not that all patients need remdesivir. First, you have to classify the patient, whether the patient fall in mild, moderate or severe, not only on clinical, but also radiological basis, which are not given in guidelines, sir. Radiological part is not mainly, they are not taking account the radiological part, sir. Again, in this time in this corona outbreak, we have seen a subset of patients, sir. They are not improving with best of treatment, sir. Whether we start remdesivir on time, whether patients are on mild category or severe category. So my thought is that remdesivir is needed, but it is not essential for treatment of COVID. And we should not create a panic around that if the patient is not given remdesivir, he is not going to improve.
We come thoda proximal. Dr. Chandrakant?
Sir, it's a history. Okay, antivirals are not effective in any respiratory diseases, especially in terms of mortality. Okay, it's a history.
Well said.
And history is, and this time also history is going to repeat now, especially if you go through the H1N1. There are many observational studies in H1N1 which showed some mortality, 28 days mortality benefit. But what are the meta-analysis they came later on? This showed only disease duration symptom. For example, if the disease is lasting for 10 days, disease may last for 8 days, especially in case of H1N1. Similarly, in COVID also, the symptom duration can reduce. This is the benefit of remdesivir. I think for this purpose, we should use the remdesivir, but we should not run behind the remdesivir. And people should not also get panic if they are not getting remdesivir, they are losing some big way. So whatever the life-saving medicines are there, that is a steroid, already it's available, and it's not out of stock. And regarding choosing of remdesivir, it is available, especially in the high-risk people presenting with some dense consolidation. Even the CT score is less, but with a high-grade fever earlier, if you want to choose, if you tell the ideal patient to start remdesivir, if the patient presenting within less than 5 days, 7 days, especially 3 days, 4 days with the high-grade fever, the dense consolidation, not only just ground glass opacities, with the normal CRP, high running fever, I think this patient, subset of patient may get benefit from remdesivir.
Dr. Rahul?
So remdesivir is not the game changer in this wave, because we have seen that patients are presenting late because they ignore their symptoms. They have a stigma that they will be labeled as COVID. So they're mostly presenting in the end of first week or second week. So in that phase, I don't think remdesivir will make more change to the management, but the game changers are steroids and anticoagulants, which alter the progression of disease.
Pratibha?
So I think I'll put it simply. We were having results before remdesivir. We have results with remdesivir, and we have results with inavailability of remdesivir as well.
Absolutely.
So I think we have learned a lot over the last 1 year. Some of the important things is about steroids, the doses. I think initially when, in the first wave, steroids were being given, but they were being given in very high doses. Patients were having a lot of complications due to steroids. So I think we have to look at treatment in totality. We can't be only talking about a single drug. We have to talk about, in totality, the treatment. And I think a lot of factors are contributing to our results. The steroids, the doses of steroids, timing of steroids, availability of remdesivir, starting remdesivir, preferably within 5 to 10 days. Okay. I think now more and more we have moved from definitely, even if we have availability of remdesivir, of not giving it if a patient is more than 10 days. Also, I think that is the take-home message, is that we need to conserve remdesivir. Even if you have a very sick patient who's more than 10 days of illness, no point in wasting that remdesivir.
Yeah. So in fact, I will say that because there was a question by Dr. Aniket from Hyderabad, what are the absolute indications of commencing remdesivir? And interestingly, the very next question came from Dr. Gyan Shankar from Nagpur, where he actually quoted the Ravi's paper of 346 patients of COVID, where what was the ideal time to introduce remdesivir, that is less than 9 days and moderate disease. And most important question came in, and a comment rather came in from Dr. Chandrasekhar Puttaswamy, again from Karnataka, that why radiological features are given any place in categorizing COVID-19. I would like to come in here, Dr. Puttaswamy, that no guidelines, whether it's ICMR, MOHFW, Maharashtra Task Force or Karnataka Task Force, we do not put radiological features to categorize or classify the severity of the disease. The classification grade 2A, 2B or 1A, B, C is purely clinical and not radiological, and thereby our decisions should be, and I would also like to be bold enough to say, as Pratibha was putting, I really don't know whether Remdesivir has helped us to reduce mortality, but I definitely know that abuse of steroids and tocilizumab has helped us to increase the mortality in COVID-19. So that almost brings us towards the end of an hour of beautiful discussion. We have another 30 minutes, but I don't think just because I have a luxury of time, we go on and on beating around the same bush. But I would like to have a quick closing remark from each of the panelists about whatever aspects of Remdesivir do you feel is the most important to be highlighted. And then I will give my final closing remarks. You can start, Prati.
Okay.
Oh, Dr. Pratibha. I am supposed to call you that.
Yes,
on
Dr. Pratibha, yes. So I think from whatever data and whatever experience that we've had, I would completely agree with our Indian publication by Ravi saying that moderate patients under 10 days, Remdesivir with hypoxia, Remdesivir will have a benefit. I'm not sure about patients without hypoxia, only anecdotal patients where fever is not subsiding and you have other comorbidities and there is evidence of pneumonia, you may use it. If the patient is beyond 10 days, then definitely there is going to be no benefit. I don't think we should waste it. And we should not bet our life on sick patients, making relatives run around for Remdesivir in critically ill patients if it is not available. We have managed patients before Remdesivir also, and we have to treat patients in totality. So judicious use of Remdesivir along with other treatments like steroids and tocilizumab is what is actually going to save our patients. Because it is not just COVID which is killing our patients at present, it is secondary infections also, in this wave especially.
So there is an error of omission and commission both happening, to be very honest, at many levels. So we need to be careful. Dr. Chandrakant?
So definitely, as ma'am said, less than 10 days, definitely we should use it if the specialist is hospitalized with moderate to severe disease. At least under cover of these medicines, we can give the steroids. I think that is a benefit. And but as I said, which is not mentioned in the guidelines, but I should say it's especially the high risk patient, especially with the high grade fevers and even with the small consolidation, especially dense consolidation in the CT scan, that is a viremia phase. We should consider the Remdesivir to prevent the progression or to reduce the viremia or to reduce the symptoms duration.
And that is your very personal learned opinion,
yes,
and we completely respect that. And you're making it very clear that though it is not in the guidelines, that's
yes,
your personal opinion. We completely respect that. Yes. Dr. Rahul?
So as we know that Remdesivir is not a wonder drug, used at the right time, it will help the patient, that is within 10 days. And it has to be used with the other drugs which are life-saving, that is steroids and anticoagulants. So I would feel, I request all the doctors, specialists to restrict the use of Remdesivir and to conserve it for those who actually need it. Especially in this pandemic wave.
Very well said, Rahul. Very well said. Man coming from Goa wants Goa to come back to life quickly such that we can have a good holiday there. So it's an earnest request to all of us. Dr. Abhishek?
Sir,
Guwahati is as beautiful. So what do you like us to say?
Sir, my honest opinion is that, sir, currently we don't know which drug is working where, sir. Because we are giving a cocktail of drug. If a patient is receiving Remdesivir, before that we start him on steroids, sir. And after starting Remdesivir, patient improves, sir. But which one has worked, whether the steroid has worked or LMW has worked or whether the Remdesivir has worked, we cannot specifically say, sir. But it is working, sir, because patients are improving. But in certain group of patients, as I have already mentioned, sir, nothing is working. Patients are deteriorating this time. Whether we are starting the Remdesivir on day 5, day 6, we are giving plasma, tocilizumab, but patients are young age, 30-year male patients, they are learning about ventilator. I mean, we are not able to save. So, making the conclusion, we can say that it is not a wonder drug. It should be used judiciously. And if it is not able, we should not create a panic around it, sir.
Brilliant.
Thank you, sir.
Brilliant team. Dr. Pratibha, Dr. Rahul, Dr. Chandrasekhar, Dr. Abhishek. It was a wonderful contribution from each and very, very well balanced and most importantly, data science evidence based. I would just like to summarize it in a very simple way that Remdesivir has a long history. It is an antiviral which has been around for a long time. There is data which is conflicting, and science always has loggerheads with each other. There are papers pro and con, and it evolves. Science, by its very innate nature, evolves. It's too early to put the drug into the dustbin, but at the same time, there is no need to feel that it is a panacea. If it's available, use it at the right time, in the right category, right? I would rather say right clinical category of the patient. No point using it after 10 days at all. And if you don't have it, it is not a panacea which is going to be a lifesaver or a game changer for your patient. With those words, I would like to thank each of my panelists and the CCI and its secretary to have given me the opportunity for hosting today's webinar. Thank you very much. It was a pleasure talking to you all, and I have really learned a lot from all the corners of the country. Thank you so much.
Thank you, sir. Thank you, sir.
Thank you. Thank you, sir.
Thank you.
Thank you.